importance of early identification and the offer of high-potency treatment as a first line. And I did wonder whether we might escape mentioning AI, but you have started that journey, so thank you. Now we move on to a questions session for the panel. I'll stay here, I think, for 2 minutes. I just want to check if the panel has a roving mic. Brilliant. And we've got roving mics in the auditorium as well, so if you have one, please put it up so we can distribute it around the room. So it's an opportunity for people to ask the panel any questions that are of personal interest, of interest to your area of work. And while you're thinking, I might just pose one to anyone who wants to answer this really, because as we were talking through this, we understand that there are many cases of unidentified fractures that we need to detect. And that reminds me of work I do in Public Health Wales, which is overseeing our screening programs in Wales for cancer detection, etc. And the whole ambition there is to offer early detection so that early treatment offers a much better prognosis. Do you envisage a case to be made for screening for missed fractures?
So that's called the FLS. So that's the whole point of the FLS is. So a missed fracture is, apart from the spine, they're all symptomatic. So to have an asymptomatic fracture doesn't really happen if it's not spine. And even for the spine fractures, we can educate patients that, and primary care physicians, if you've got back pain and you're losing height, you've got to get imaging. It's not very complicated. And that's the whole point of the FLS. Is, usually I talk about screening, is picking up asymptomatic people, by definition, who don't have a disease. If you've already had a fracture, that's osteoporotic, that's not screening, that's just clinical management. And I think people get confused between the two. And the best FLSs I've seen have like loads of ways to find patients. They'll use radiology reports, they'll use scanning, they'll use virtual clinics, they'll work with pharmacists, they'll outreach to frailty teams. You can widen your net. And I think that would be the way forward. But I would just say, if you want to go down that path, really invest in your FLS digital tools, and they can do it digitally.
And I accept that the FLS has played a key role, but in a population screening program, it's a systematic process that identifies an eligible cohort so everyone gets invited. And it strikes me that the opportunity for detecting more is more streamlined into a pathway. But it clearly needs investment and commitment to the rest of the care pathway. Does anyone else want to address that from the panel?
I just want to say that we are on a phase 1 in Wales. We are still trying to identify those visible fractures rather than invisible fractures. So that's our next phase. And that's where a whole part of the secondary fracture prevention or prevalent fractures will be working on. So thank you.
Thank you. Now, can I just scan the room again? If you've got a question, please do put your hand up or stand up, make a noise.
Hello.
Brilliant. There's one at the back there. Thank you.
Do you want me to start speaking? Hi. My name is Helen Cordy. I'm a consultant in metabolic medicine. I've been annoying everyone by referring patients from the intestinal failure service to their local osteoporosis service. So I apologise for that. I have a question about what the preference is really. I'm not sure whether you'll be able to give me a clear answer, but clearly giving someone treatment is better than giving someone no treatment. And when we get these very high risk patients where perhaps we feel that anabolics are the way to go, which is what the evidence is suggesting, but there may be a wait for the patients to access that. I guess from someone who hasn't got access to those medicines, is the preference that we go in with IV Zol, which, as Professor Johansson said, is immediately available to lots of people, or is the preference that actually these patients should wait to go to a specialist centre to receive the anabolic treatment? And I guess for the people who don't have access to those medicines, what's the preference from you guys for what we do?
So I'm talking about a group of people who are lying in front of us with a Venflon in their arm.
who in 2021 were essentially ignored by the health service. And we've given most of them now are getting sedentary. That's not the best treatment, but it's, as you say, much, much better than nothing. And it's still not being delivered everywhere. So raise the bar. That's all that I'm arguing, is to get the baseline up. I would agree there are much, much more effective treatments if you've got an FLS that will take on delivering that. Our problem is that we don't have FLSs that are taking on and delivering all of those better treatments that we ought to. I am quite uncomfortable with the idea that somebody lying in hospital with a broken hip gets labelled as, ooh, this person's wrong as osomab, so let's not give them anything, or put them onto an endless pathway for a very expensive drug that they may have died before they receive. I don't feel comfortable with that, but there's no good reason why you can't give a dose of Zeledronate with a view to PTH. Sue?
I think it's about leadership. So there's no reason why an FLS nurse can't lead and have the expertise to deliver anabolics. It's nothing magical about seeing I'm a rheumatologist. I don't ask different questions I can ask about heart disease, so can a nurse, so can a pharmacist. So if you really want to truly deliver that anabolic vision within your FLS, do not refer them to medics. Keep it all in-house. We run an MDT every Tuesday morning. It takes 90 seconds to decide if they're anabolic eligible. The criteria are really clear. And I think what really comes down to building nurse leadership and having a regional network where you can share expertise. You might think, oh, that's crazy, my FLS nurses, they can't do that. But actually, that's the way forward. The minute you make it, as Anthony said, sticky and depend on the medics, the pathway falls apart. So don't go down there. And we decided very early on for 250 anabolic patients a year. There was no way they could come through our pathway, so now it's a nurse-delivered pathway. And actually the nurses are probably more competent and more comprehensive. I'm sorry for the trainees, but the trainees are not as good. And even I'm not as good. And actually if you want the job done, put it in a pathway, systematic, everything's recorded, and keep them away from the medics. Because the medics just confuse the issue. And it's almost like, why do we need to see a consultant when the guidelines are so clear? Of course there are exceptions, but I would say 95% are no-brainers. They've had a fracture, they're very high fracture risk. And the problem with giving them an anti-resorptive before the anabolic is you will lose 30% of the benefit. And if you're doing that because your pathway doesn't work, that's a system problem. It's not a medical problem. And that's what the clever people in the system design can fix for you. And share practices. There are other centers. Zoe Haskins does the same in Kiel. They're doing these MBTs that are anabolic. And just go and visit them and see what it does. People have fixed that problem. Your problem is not unique, but it is fixable.
Thank you.
Thank you. I hope that's not going to be the quote of the day, keep them away from the medics.
I actually do think that should be the quote of the day. Because if you look at it, how long have we known about FLSs? Since the end of the 1990s. And look, the graph is still so bad.
Yeah. Point well made. Thank you. We have a question from there.
Hello, good morning. My name is Irina Hafagri. I'm a GP. I work in Swansea. You mentioned Professor Jabin, you mentioned the importance of picking up recent fractures. Is there a clinical reason for that? Is there something that we need to think about? I'm thinking about my patients who end up coming back with a report from A&E about a vertebral fracture. They don't get picked up by anyone. Yeah. I prescribe some vitamin D and that's about it. Sometimes I refer them for a DEXA scan. Is there something missing in this journey?
So calcium vitamin D doesn't reduce fractures. Let's make that super clear. So there's another systematic review showing exactly the same thing we knew 10 years ago. We don't know why recent fractures cause more fractures very quickly. We haven't figured it out. There's something going on with the biology, we don't know. But if you've had a recent fracture, you're on a completely different risk group. And, the ROS has really pushed this, it's the FLS, Rafa's model shown as well. There's something really bad. It's almost like a TIA, or it's actually the same risk of a heart attack to another heart attack, but it is exactly the same 9-12% range. And so when you see someone with a recent fracture, that could be back pain, x-ray shows fracture, I'm not quite sure when it happened, x-ray just shows fracture, get on and get them on to treatment. Don't wait.
Please add a very pragmatic answer to that as well. Now, in Wales, we are in a different phase of developments in different regions, different health boards. So if you do find a report coming from a radiologist with a fracture, please do look at the notes whether the FLS been involved or not, because we're still missing 50%. And if you do find that person is not under FLS, please follow the regular ways to refer, otherwise we'll continue to miss that and it will be a missed opportunity. So please look that carefully. Thank you.
We've got a hand up here, but while we're waiting for the mic to... Oh, we've got one at the back, thank you.
Thank you very much. My name is Raja Viswas. I'm from the FLS service. Question to the panel about patients who is identified, because we have adopted a pull-in model, and we often identify patients who has had a fracture but has got a high clinical frailty score, because that's something which we assess when we initially have the discussion. So a clinical frailty score of 6 or 7 or above, or underlying malignancy undergoing active treatment. Are these patients suitable to be having bone protection? What is the panel's opinion about that?
So if you're knackered and you've got a poor clinical frailty score, you're likely to fall over and break something. If you've got malignancy, you're likely to fall over and break something, and you've got holes in your bones, you definitely need to be on some form of treatment. And zoledronate is a very simple thing to do. If you're contemplating not giving them treatment because they're really sick, that doesn't make sense. That doesn't make sense to me at all.
No, I'm not suggesting that at all, Anthony. What I'm asking is, what is the panel's opinion, whether they should have oral treatment, because all these patients are outpatient based in the living in the community. And not all of us have access to give IV zoledronic in a setting for all the patients that we can identify.
Oral treatment will make you feel better and her feel worse. It's not an option. I think we should just move on from oral. Osteoporosis is treated through injections.
Thank you for that clarity. Anything to add from other panel members? If not, we've got a question in the front.
Hi, Andy Hayden. I'm a medic from Haldar. So, that's been an interesting start. You're absolutely right, Anthony, about the current situation around hip fractures in Haldar, and the data is so bad that if any of my family members fractured, I think I know which hospital I'm going in the direction of. That's not for lack of trying, especially recently. And in terms of trying to, show the evidence, internal drivers within the health board have been completely unsuccessful really for the last 6 months, saying this is the problem, we know this is a problem, and all you end up is arguments about where the money's coming from. So the question is, I suppose, how can that be driven externally, with pressure on the health board, on the chief exec, on the medical director, to actually make this a priority to do something? Because when 6% of your patients leave the hospital after a hip fracture with, which means 94% actually get no treatment whatsoever. They don't even get a vitamin D level now. That's the situation we're in one of the hospitals in West Wales.
Yeah, well, I haven't done a vitamin D level on anybody for a decade.
Sorry, I should rephrase this, they get no bloods at all related to osteoporosis.
Yeah, I'm not sure that I've done very many of those either. Why not
Or
just
Zol.
get on and treat them? They're not giving Zol, and that really is a problem, because it is incredibly straightforward. Where's the money coming from? Well, you just close some beds because you stop breaking things. Since we wrote the paper explaining how to use the zoledronate for dummies, there are tens of thousands more people having zoledronate. We have prevented more fractures than will be admitted to Inda and my hospital and Morriston, just through the zoledronate protocol. So, if you want to just do something to make it look as though you care, and recognise that osteoporosis is a real issue, then giving people zoledronate doesn't require investment. It doesn't cost anything. It's where where's the cost? It's like giving your patients with Letromate. It's no cost associated with it at all. The house officer and the pharmacist can do it. The drug costs for the whole of your population in Helva are a few £1,000s for drug costs. So there's no economic justification for just, well, let's have some more beds for orthopedic surgeons to worry about while people are in hospital for a month. You've got to get that baseline out.
So I actually do see that a lot, where you think, as Rafa says, the clinical argument is so clear, and actually you need to take your hat off as a medic and actually become a rehabilitation doctor and a business person and a communicator and take your patients with you. So it's shouting at people saying, that's why you do, the clinical argument is very clear. And you need to, what often happens is actually there's someone in the chain who's got the message wrong. And it's your role as the lead clinician for that specialty to bring your army with you, your nursing colleagues, your pharmacists, your patients, and just figure out where in that chain of command there's been a miss-up, and then spend the time fixing it. It is really boring. We had the same thing in our hospital. It might be a coding issue or something, but somewhere in that chain of command something's gone wrong, and you just have to have that resilience to not give up. The most successful FLSs I've seen, they've got leaders who never give up. Like India, just keep going. And it's not that you have not kept going, it's just maybe your army hasn't got the right, you haven't got enough patience with you or something. Something's gone wrong in that chain of command. Maybe a pharmacist who's a bit sticky about killing soul within 2 weeks of hip fracture, or something ridiculous like that. But you need to find out what it is, because just shouting at them, it doesn't work. You have to actually get them on board, and you just have to find one person.
I'll just add to that, it's okay to annoy your leaders, your bosses, it's absolutely fine. Knock the door again and again and again. You only need one door to be open to get you in.
Very practical.
Can I also offer the support of the charity on this? Sometimes we find that people have conversations internally and there are blockers, and sometimes it's hard to advocate internally when there's a sense that somehow you're creating difficulty for people and so on. And that's where we can come in. You know, we're independent, we represent patients. Sometimes we find that with the best will in the world, things don't change unless an outside charity happens to write to a chief executive, copying in a local member of the Senate, asking, you know, what accounts for this data. So if you want to talk afterwards and send me the data, we'll give that a go as well to keep some air cover.
Brilliant, thank you. We have one final question from the middle of the room.
Hi, Jack Boylan and Cardiff Vale. Questions largely already been answered by people talking then, but fractionation shows us going through a lot of good, positive change at the moment. And obviously the clinical evidence and financial evidence for fractionation services is overwhelming, yet you still encounter those challenges with trying to not force through that change, but get people on board within organisations where we don't have immediate contact with them. What are your experiences and sort of your reflections on overcoming those challenges in your own fields?
So that's a really good question, and it's about that teamwork and actually being honest with your providers. So actually say, look, I'm not going to change the world, I'm not going to prevent fractures in a year, this is a 3-year program, this is how it works, giving them faith, and speak their language. You know, your health board will have a vision statement. They'll have aims and objectives for their health board. You have to download that PDF that's 100 pages long, that's got their vision statement, and then pick out all the bits that are aligned to FLS and personalise them. It is that tedious, and it seems a bit silly, but as a consultant that's what you have to do, or as a senior nurse, and you have to speak their language. They have a job to do as well. They're not impervious to health and inequalities, but unless you're speaking their language with patients next to you, it won't work. And try and de-risk. I've seen so many FLS business cases with nothing about risks. And unless you tell your payer, this is the risk of it not working, this is how I'm going to make it less likely, that comes across as slightly dreamlike. So identify your risks and mitigate them. And there's a really nice, there's lots of structures, FLS Academy Network, there's lots of tools you can use. But it is stepwise, having leadership, working with patients, and just being resilient. And I know, Jack, you had a heck of a time taking over where you are guidelines, the same everywhere else, we still have that. But it's just being persistent and realistic with your commissioners. And don't promise too much, and be honest with what the risks and mitigations are. Those are the things. And use Rafa's data. It's really compelling when you put lots of numbers. And the ROS's data, when you change those patients to thousands and hundreds of thousands and sometimes millions of pounds, that does shift there. But it is working.
I'll only add to respect patient's patient story remains the key when you're fighting your case. Take a patient story with you, either record it or take patient with you. Thank you.
Thank you. Thank you for those questions. Really thought-provoking, quite technical in some places, but really important to recognise that what the panel has demonstrated to us is that that whole journey from setting your strategic ambition through a quality statement and how it translates into the front line and setting up services that actually meet those needs. But underpinning all this is the advocacy that we've heard very strongly throughout the day, not just from patients, but also from our community and voluntary sector, charity organisations, and our policy makers and politicians as well. So it's really good to have that all working together. Something Craig said reminded me of a musical, Calendar Girls, which is set in Yorkshire, you may know it. WI volunteers who pose nude on the calendar to raise funds. And one of the really striking things from that musical, Craig touched on this, which was about acting the colour of your hair. Now it relates to me, so I can relate to that. So don't act the colour of your hair, act the colour of your heart. What I'm going to take away from today is that it's not about acting the colour of your hair, it's actually acting the density of your bones. So thank you all very much. But before we finish, I want to pass on to Inda, who's got a special message.
Just to say thanks to you all, but particularly I'd like to thank Craig Jones. It's been 6 years he's been here, and over the last 6 years I think I have been knocking that door, and I must have annoyed him on several occasions. But just to thank him, I just wanted to say this is my apologies. Being annoyed on several occasions, and that's a little thing on behalf of Wales. And it has got a logo of Wales Boat Health, and we just want to thank you for this.
To our session with refreshments and networking opportunities, and we come back at 20 past. Well, we'll probably make it a little bit later, but 20 past. Okay. Thank you.